Dr. Averhart, thank you so much for joining us on MD Newsline. Can you please introduce yourself to our audience?
Yes, thank you. I am Dr. Averhart. I'm a general pediatrician and obesity medicine specialist. I practice general pediatrics in Chicago on the South Side, and then I also do obesity medicine for adults and children online via consulting.
So, we're going to talk about GLP-1s today, which is a really hot topic. Tell me a little bit about how you're currently using GLP-1 receptor agonists in your practice, and has it changed at all from when you started to now?
Yes. So I've been practicing medicine for about 9 years. And over those 9 years, we've gotten different FDA approvals for different GLP agonists. I practice specifically with weight loss based medications and FDA approved medications. And so those have come online in the last few years or so, and they've been very popular. So in the last 2 to 3 years, I can attest that it has just skyrocketed in the number of people that are interested in it and taking the medications. So in my practice, I prescribe the medicines. I do consultations to see if you are a good candidate or not, and then manage once you're on medication.
So, when you think about GLP-1s, do you conceptualize them primarily as diabetes drugs that also cause weight loss, or as obesity and cardiometabolic drugs that also treat diabetes? And does that change or influence how you prescribe it all?
I categorize the medications as both. And yes, it changes how I prescribe. And I think that is typically pharmacologically based, because you have to choose the different medicine based on the FDA approval. In general, they work in the same way, and they're technically, for the most part, the same medications, just branded differently.
Mhm. So, where do you see the biggest unmet need in primary care that GLP-1s are actually helping you address?
Obesity. Uh, I know diabetes management was first to utilize these medications, and they have really been helpful in managing that A1C glycemic control. And we know a lot of diabetes, especially or essentially type 2 diabetes, is related to weight and what we're eating. But obesity in general, because these medicines have been helping people lose weight over time. And in primary care, obesity is really the number one condition I see, and then obesity is definitely a risk factor for all the other conditions that can be treated, including diabetes.
So, can you walk us through at a level for busy clinicians what GLP-1 is, physiologically and how the agonists work at the gut, maybe pancreas, brain, and even cardiovascular level?
Yeah, so I'll give you the spiel I give my patients. So there's three ways that it works, okay? GLP agonists, they work on your pancreas to increase the amount of insulin you're producing so you break down sugars better. And that's why it is the go-to medicine for those that have diabetes. It works on your gut to decrease the emptying and motility. So that way you feel like you just ate a whole bunch of protein. So things aren't moving as fast, you stay full longer. And then it also works on your brain to decrease the signaling. So you don't feel hungry. You're not having those cravings that are coming from your brain. So those are the three ways that it works. And when you put all three together, you have a superpower. You can avoid a lot of the foods that are unhealthy.
So, from a practical standpoint, which clinical effects do you see first in real patients? Is it glycemic control, appetite suppression, weight loss, blood pressure, lipid change, or is there something else?
So I think how the patient feel really comes first. Those other metabolic changes obviously take time, and it takes time for us to do those labs. So first and foremost, I hear a lot of patients say, "Hey, I didn't feel hungry. I took the medicine, and that same day, I pushed the plate away." So that's the first thing that I'll see.
Let's talk a little bit about patient selection and indications. How do you decide who's an appropriate candidate in a typical primary care panel? What are your green flags and what are some of your red flags?
That is a very complex question, and very individualized approaches is what we use to make those decisions. So, in a primary care setting, it can take some time because you have to encompass the entire patient. So, number one, a green flag is if you have those FDA approved indications, meaning for Zepbound, it is sleep apnea. For semaglutide and even Zepbound, it is obesity. For Monjuro or For Mounjaro and the other semaglutide, I forgot the name, it is diabetes. So you have to have one of those FDA approved indications initially. After that, then we just go through your history, your current conditions, current medications to find out if you're a good candidate. And so I could go on and on about the different things when we go into those details.
So, walk us through your thought process when a patient with, say, type 2 diabetes and obesity sits in front of you. When do you escalate from metformin and lifestyle to adding a GLP-1 into the mix?
So right now, the current practice when it comes to obesity is a GLP, and even diabetes is a GLP medication. So metformin, if the patient is extremely averse to injections, has been on metformin for a good while, you can continue it. But I don't see a reason not to try a GLP unless they have a contraindication.
How do you approach prescribing GLP-1s for obesity without diabetes, especially in patients with multiple cardiometabolic risk factors?
So my approach to prescribing GLP medications to those that have obesity versus type 2 diabetes, um, to me would be the exact same. I don't prescribe it for diabetes, so that's not really my thing. It's really for weight loss. But I would use the same criteria that I always use, which is looking at if the person has a FDA approved indication, if they have any contraindications, and if they're able to tolerate the medication and dosing titrations.
Cool. So, how do you navigate patients who are highly motivated by, let's say, social media narratives about GLP-1s, but may not meet guideline based criteria?
So first of all, I don't prescribe based on just what you want to have. So I have had patients come in for GLP medication and they are in a normal BMI. They do not. They are not a part of an ethnicity that would allow me to kind of lower the threshold for BMI, and their waist circumference doesn't meet the criteria, and neither do they have any other approved FDA indications like sleep apnea or diabetes type 2 or anything like that. In those cases, I just try to politely explain that the risk outweigh the benefits. And so GLP medications can seem like a fit for everybody, especially when you see how much weight everybody's losing and oh, it's making me feel so great and my knees don't hurt. Yes, but there are risks associated with it. And so those risks can include pancreatitis. Pancreatitis is a very, very painful condition. Nobody wants that. It could include gastroparesis, where your GI tract just kind of stops and slows down and you're not pooping. You're very uncomfortable from gas. And these are the things that I'll explain and say, hey, the risk outweigh the benefits. But ultimately, I don't think you're a good candidate.
Mhm. So, how do you structure your titration schedule in real life? How closely do you adhere to package inserts versus individualizing based on tolerability?
Yeah, so that's a really good question. When it comes to titration, everybody has the approved way to do it. And so typically you go up small, little by little by little, as the patient is tolerating each dose. I do have some patients that prefer to stay at the minimum dose tolerable and never want to go up because they're getting what they are looking for. I do have some patients that want to move up quickly and go up to that highest dose tolerable. In general, the titration schedule is to go up until you reach that maximum dose, and that is your weight loss dose. And then you start determining if it is effect or not an effect from there. But if you are losing, you know, let's say 5 pounds a month, you're not having any side effects, you are energetic, then you can stay at that lowest dose tolerable. So it really is a conversation between the physician and the patient to determine what is working for them. But in general, I kind of feed off of what the patient is telling me as long as we're not doing anything that would be adverse to them.
What labs and clinical parameters do you check before initiating, and what do you monitor in the first, let's say, 3 to 6 months of treatment?
Yeah. So when it comes to initiating medication and monitoring medications, there's a set of labs that I always do. So first, I'm looking at your thyroid. Because a lot of people will come and have problems losing weight, and some of it has to do with the thyroid hormone. So we check it and see if it's low and needs to be replaced. I also check for diabetes or pre-diabetes. One, that may actually help with the approval process for the medication. And second, it is a marker that we can continue to monitor. If you happen to be pre diabetic before the start of medicine, when we recheck, you may not be in that level, which is a positive outcome when it comes to the medicine.
Mm.
The other thing I check is your kidney functions. And so these medicines have been shown that in those that already have kidney issues or chronic kidney disease, they can be very, very helpful in slowing down that progression. And then also, what we know is once you start GLP medications, that thirst reflex really goes down with your hunger reflex. And some people have a hard time drinking enough to keep their kidneys acting right. So we highly monitor that kidney function. And then the other end is a cholesterol panel. And so what I frequently encounter is that some of my patients that are overweight, they're not eating as healthily as we'd expect. And so sometimes that cholesterol can be higher. And so watching the cholesterol gives us something that we can look at as a non-weight based positive outcome if that were to occur. And then the other thing is those cholesterol levels can start to increase if you're having a side effect like pancreatitis. So keeping a good watch on that helps us in both fronts.
Can you share a concrete example of a patient where you had to significantly slow titration or back off the dose? And what did you learn from that case?
Yeah, so when it comes to significantly slowing titration or backing off the dose, when I've done this, it's usually due to side effects. And so I try to goal set and level set with my patients when we start medications that there have been very, very good outcomes, but there are always a chance of side effects. And when they do occur, we talk about it, we decide what are the next steps. So for one patient, I had her kidney functions started to worsen. They were normal, and then it was like, oh, okay, things aren't looking all that great. So hey, maybe we won't go up this month. We'll increase our water intake, see how you're doing, really focus on that, and then check it in 3 to 6 months and see what happens. That patient thinks was fine. Once they started increasing their water intake, kidney functions were normal. We could continue progress. Other situations where a patient had an episode of pancreatitis while on the medicine, hey, sorry, we have to stop the medicine because these medicines truly work by increasing the action of your pancreas.
Is there a point at which you consider a GLP-1 trial unsuccessful? And how long do you usually give it before reassessing or switching?
Yes, another great question. So, can a GLP medicine be unsuccessful? Yes. Technically, if you've been on the medicine for 3 months, meaning you're not at the small doses, you're at the top dose, and you have not had a good weight loss, 5 to 10% of your body weight, then hey, we need to reconsider. We need to say, hey, do we need to try a different medicine? We need to really go into what we're doing in addition to the medicine because what I find is that some people will start the medicine and think that that is the end all be all of how you will lose weight.
Mm.
It is not it. In a lot of people, you have to eat more healthy. You have to get your protein in. You have to be more active. And so then we kind of reassess where we are with all the other components. But typically, if you've been on the medicine for 6 months and you haven't had that 10% weight loss, then we need to figure
Mhm.
out if it's successful.
So, nausea, vomiting, constipation, and reflux are big complaints when it comes to side effects. What's your approach to preventing and managing these GI side effects?
So there's a few things. So when patients start medications, they're at the, I guess, highest or greatest risk when it comes to GI upset because your body's changing. Your GI is getting used to these things. And then, of course, the medicines work by slowing down your GI tract. Slowing it down in general can cause you to have more gas, feel more bloated and nauseous. So, number one is just watching what you eat. Okay. If you're eating a lot of beans and you're trying to really, really get that fiber up, you might be getting a little too much fiber. You got to pull back a little bit on that and see if that helps. Drinking enough water to kind of help increase your gut motility, even though you're on the GLP, as well as exercising. Those are all good things that are going to help with that. You can try over the counter like anti nausea medicine, and then just kind of seeing what's the smallest dose of medicine you can be on where you don't have side effects. So, say for instance, you're on the 0.25 milligram semaglutide and Ozempic, and then you go up and you're at zero point 0.5, you're at 1.0, 1.0, oh, now I'm nauseous. Okay, maybe we should go down and see if that is the best tolerable dose and give you more time on that dose to see if your body adjusts. So there are lots of different ways that you can manage those side effects. But I think the key with managing side effects is that you have to have somebody to talk to and somebody that can work through these things with you.
So, how do you counsel patients around more serious but rare concerns like pancreatitis, gallbladder disease, or the theoretical thyroid cancer risk without either maybe minimizing or catastrophizing the situation?
So I'll start with the thyroid cancer risk. So whenever a patient starts a GLP medication, we talk about serious side effects that can occur. One of the more serious is the medullary thyroid cancer risk. And so what we know is that those that have that family history of a particular syndrome called MEN type 2, they're more at risk for medullary thyroid cancer. So in general, I always ask patients about thyroid cancer in the family, if they've heard of this syndrome and if that syndrome is present. And if it is, then we absolutely will not start the medicine because cancer is too high of a risk. And then when it comes to like pancreatitis and gallbladder disease, we talk about how we'll do our follow up. So, follow up is really important. We're monitoring your cholesterol in your labs. You're telling me about if you have belly pain. We're following up every 3 to 6 months. We're constantly monitoring to make sure that if something like that were to occur, we would treat it, we would figure it out, and it wouldn't just be something that happens.
Interesting. So, have you seen any mental health, eating behavior, or addiction related effects in your own practice, let's say positive or negative, and how are you screening for those?
Okay. Yes, yes. So each patient that I see, I do a eating disorder questionnaire, binge eating disorder questionnaire, and we go over it and we talk about it. If you have a history of binge eating disorder, you should, get counseling and do everything that you have been doing to treat that condition. These medicines are not used to treat any type of eating disorder. And so I make sure I allow my patients to understand that. And then, as far as those that may have a previous history of binge eating disorder, and then they're on the GLP medications, I have heard anecdotally that it helps them feel like not the binge. They don't feel as like, I guess, the desire to eat like they used to. But we don't use these medicines to treat any eating disorders, and those that have active eating disorders should not be on these medicines.
What's your approach to procedural or preoperative management with anesthesiology teams, given concerns about, let's say, delayed gastric emptying?
Okay. So when it comes to surgery and GLP use, I think surgeons now just kind of assume that every patient they're operating on is on a GLP. I've seen lots of papers where it's just like, if you're on a GLP, stop your GLP at least a week prior to surgery. What that does is allows your body and your emptying to go completely out, because one of the things with surgery is you want to have a completely empty stomach. So if you vomit, you're not aspirating. So in general, I think it's about a week before the surgery that you'll stop your GLP medication. Um, yeah.
So, how are you framing duration of therapy? Do you present GLP-1s as a long-term, potentially lifelong medication or as time-limited interventions?
Great question again. So, when it comes to GLP medications, I always tell patients that this is a medicine that is designed to stay on for a lifetime or a long term. Okay. And the reason is because obesity is a chronic condition. Obesity, at one point, people thought, oh, if you just eat right and exercise, you'll never be obese again. What we're finding is that obesity is a chronic, relapsing condition that you have to do something to treat. Whether it is you are counting calories, whether it's you're an avid exerciser, whether it's you're a biker, you're doing something throughout your life course to either stave off obesity or manage obesity. And so that is the approach. With GLP medications, obesity is not going anywhere, and so are these medicines not going anywhere. So you have to accept that if you do decide you want to come off of the medicines, that your chronic condition will no longer be controlled. And so then that paves the way for a conversation of rebound and relapse.
Mm.
What we find is that majority of people who stop GLP medications will gain all of their weight back and some within 6 months. I have heard some anecdotal information about sometimes you'll gain about 4 times as fast as you would if you weren't on obesity medicines. So, those are the realistic conversations we have to have so that they know that these medicines are long term and not meant to just be get to my goal and leave it.
So, when a patient achieves substantial weight loss or, let's say, glycemic improvement, what criteria do you use to consider dose reduction, maybe spacing injections or just stopping entirely?
So I don't recommend spacing injections. I know there are a lot of Facebook groups, blogs, and um, patients that will say, "Oh, I only take my GLP once every month or every 2 weeks." I do recommend continuing every week. As far as dose titration down, if you're at your goal weight and you feel like you would like to get to the lowest dose maintainable, maybe you were having some nausea at the highest doses, you were tolerating it because you knew you had a goal to get to. And now you want to go down to see if the nausea, that is perfectly fine. Just as long as you do it month by month and you really take inventory of how your body is adjusting and how you feel.
What has been your real world experience with weight regain or metabolic rebound after discontinuation? And how do you counsel patients upfront about this?
Yeah. So when it comes to weight rebound and gaining weight after a GLP, uh, I have the conversation up front that it will happen. I'm almost 100% certain that it will happen. And so you do have to think about that before you start medications.
Mhm. Does that impact what's typically the response? Is there a plan? Does it impact decisions around whether or not to take the medication or anything along those lines?
Yeah, so I think it's a very personal discussion that has to be had with the patient. Yes, it does impact our conversation as far as the adjunct things you can do. The weight gain is going to be way faster if you're not exercising, if you're not trying to eat a healthy meal, if you're not counting your calories, if you aren't adhering to a protein goal. So there are lots of things you can do to try to slow down that weight gain. And that's centered around all the other things we talk about when it comes to weight loss.
So, access and cost are huge issues. How much of your GLP-1 prescribing is maybe dictated by insurance coverage, prior authorization, and formularies versus strict clinical preferences? And is there anything that you do or that you recommend for people who maybe might not be able to access?
hmm So the prescribing of medications in general in the US are dictated by formularies, pharmacy, prior authorizations. I can even say for my children that have asthma and I'm just using an asthma controller medicine, the pharmacy will say, or the insurance company will say, no, we don't use that one or we don't approve of that one. You have to do a different one. So it definitely applies to these GLP medications. So depending on the situation with the patient, if they happen to be a very well-to-do patient and they say, "Hey, I can spend $1,500 a month on a medication. I specifically want this," or I say, "Hey, I think this is going to be a good fit for you," and they say, "Hey, I don't care what the insurance." That's fine. But if the insurance comes back and says, "Hey, we're only approved this medicine," then a discussion has to be had with the patient and myself where we say, "Hey, is this a good fit for you? And is this something we think would be successful?" And so it's really a conversation. But insurance companies do what insurance companies do.
For clinicians who feel behind the curve on GLP-1s, what are one or two simple practice changes they can implement this month just to kind of get up to speed?
Education. So if this is something that you're kind of hesitant about, if you've never prescribed a GLP medication and don't know what to do, try to find some education. There are lots of CMEs or continuing education courses, and there are even conferences like the Obesity Medicine Association that you can go to. You can look at their website and get more information about how to start. And the start is the education on your part. You don't have to prescribe, but should get some education.
Mhm. Thinking into the future, let's say 5, 10 years, how do you think GLP-1s and related therapies might shape primary care and chronic disease management?
That's a great question. In the obesity medicine world, there is a lot of hype and talk about up and coming new medications. And so we have our GLPs, we have our GLGIPs, we have retatrutide, we have other medicines that are in the pipeline, oral injectables. And I think at some point, as they expand the FDA approval for different indications, like now we have Zepbound for sleep apnea, they're going to become standard of care for different and a variety of conditions. So, as primary care doctors, I guess what we can do at this point is just understand, see where we are, gather the information, and understand that the future may entail using these for other conditions outside of just obesity and diabetes.
Mhm. What questions do you still have as a prescriber, either about long term safety, cardiometabolic outcomes, or health system impact that you'd most like to see answered by future research or data?
Probably long term impacts and how this fluctuation of weight going up, down, if you get off, you lose the weight, or if you get off, you gain the weight, how that impacts each person individually. So, really, just long term studies. And when I say long term, 20, 30, 50-year studies clinically, how these medicines are impacting people.
Wonderful. Well, this has been an amazing conversation. Thank you so much, Dr. Averhart, for joining us on MD Newsline.
Thank you.